Hi, everybody. Welcome to this week's Benefit Buzz. My name is Elena Gambin. I'm the Chief Growth and Strategy Officer at First Stop Health. And normally I am coming to you live, but this week is a little bit hectic in good ways. We're doing a lot of travel in the market, getting out, visiting you all personally and in person. And so this week, our Benefits Buzz, which is about care navigation and the ways that we are enhancing it, is pre-recorded, but I'm always happy to answer any questions that you have offline after the fact. So today, I'm going to start, as I always do, with a reminder of who we are, and then I'm going to dive in pretty deep detail about what our navigation service is today and how we have enhanced it specifically with the acquisition of Century Health, which you all are familiar with. So, First Stop Health, virtual care company, direct virtual care company serving over 1 million members nationwide and over 1,000 employer clients nationally. Now, if you've been here before, you know that our ethos and our mission is to provide affordable, delightful, equitable healthcare experiences. The detail of patient care is what makes this solution special, and our North Star is engagement. We have some of the highest utilization rates in the industry. Across our entire book of business, our average utilization is 60%, and we support clients on all spectrum from small, fully insured law firms to large, self-insured trucking populations, medically enrolled, part-time populations. And we have a lot of pride in helping the craft work of the world, people who help other people. Now, in order to kind of set the stage for why we have invested in our navigation solution, it really centers around the fact that the thing that navigation or advocacy or steerage or care coordination or whatever you might call it, because there's a lot of names for it, the thing that it is built to do is to solve the adherence problem in healthcare. Non-adherence to prescribed care paths or to what we know we should be doing, it's a problem of infrastructure, it's a problem of equity, it's a problem of access, and it's often a problem of psychology. As human beings, we're often inert. We don't always take action when we know that we should. 92% of adults in the United States do not receive all appropriate preventive services. Almost every single adult in the United States is not getting 100% of their preventive care. In the last few years, 44% of patients completely skip care that's recommended to them. And 60% of adults, and that number is actually increasing slightly, have not seen a primary care doctor or don't even have one in the last year or more. And so when we think about why this is happening, as I mentioned, a lot of it has to do with cost. A lot of it has to do with availability. A lot of it has to do with the fact that patients feel like healthcare isn't speaking to them as a person. And mostly it's just that patients need more help. And so when we have been thinking about where we sit in the spectrum of support and how we can help people, historically, with our mental health products and our primary care products and our urgent care products, we've existed across the spectrum of risk, but more indexing on the low, unknown, or moderate risk populations. With enhanced primary care and navigation and true chronic disease management and care coordination and case management, all of which we'll be talking about today, we are really kind of edging towards the more active, reactive component of healthcare, the service of people who are emerging risk or high risk, the smaller percentage of the population that actually makes up the bulk of spend. These are our high cost claimants. These are our folks who are undergoing oncological treatment. These are our folks who are experiencing high cost surgeries, renal failure. There are so many people who not only need more support for themselves and their families emotionally, but also financially, and that also trickles down to the plan. So when we think about what navigation means, we have a unique approach to navigation, particularly as it's tied to primary care, because historically primary care has been what you might call benefit agnostic. You go see a primary care doctor, you spend 7 minutes with them. They don't really know what your benefit looks like, what your plan design looks like. They aren't recommending care that is truly integrated or optimizing for your financial and benefit reality as a patient. And they are very infrequently coordinating with your other providers. So for us, from a tactics or a benefit perspective, navigation and advocacy looks like understanding fully the benefit ecosystem in which a patient lives, steerage to other benefits, smart steerage within the network, the ability to both provide and respond to wellness incentives, the ability to integrate from a data perspective with other entities, broker or consultants, data warehouse, the TPA, and then having pretty strong data integrations with any lab imaging and prescription vendors so that there is a real-time result return. So this is sort of the non-clinical component of navigation, and we'll talk a little bit about it. But what we also have done is we've taken the non-clinical component of navigation and we've added access to a team, or in some ways a hotline, of nurses, advocates, and case managers who are there to support the full spectrum of anybody's health journey. Now, these nurses are trained not only in supporting a patient's relationship with the primary care physician and following up or helping close gaps in recommended preventive care or chronic disease management, but they really are there to provide secondary or complementary clinical guidance for a patient who wants to interact with a nurse or who has follow-up questions in between visits, even if they're not with our primary care doctors. They're here to support the referral process when we know we need to send someone in person and we need to find the highest quality, lowest costing in-network option. And they're there to answer benefit questions, whether it's related to how something might be covered, to why a bill doesn't match an EOB. Really, clinical and benefit can't be divorced when we are properly serving a patient from a navigation perspective. And again, this advanced clinical and benefit navigation, which sort of stems from that ecosystem of integration I described before, this is available in our primary care program. This is available in specifically our enhanced primary care program. Now, for patients who are even more high risk, we have case management. And this is what you think of when you think of the term certified case manager. It rivals, but I think it improves upon the carrier model of case management. Our case management targets high risk, high cost populations. It is ongoing support from certified case managers and nurses and advocates in typically one of three ways. Either it is advanced coordination for patients who need sort of more than what just typical nurse navigation might provide because of the complexity of a benefit request or the complexity of a disease area. It's event triggered, helping patients during or after a high cost event like a heart attack or a hospital admission or a bone break or a stroke. And it also is support of high acuity diagnoses like renal failure or diabetes or an oncological episode, a new cancer diagnosis. And some of the things that make our case management special is the patient to case manager ratio, the caseload. Our caseload is typically below 50 per nurse, which is 2 or 3 times better than what the carrier typically sees. We also have a model which allows our case managers to spend as much time as they need to with a patient and their family in order to do the right thing. So that might look like 2 to 3 touch points a day during a really intense time of an episode, conferences with other providers, a lot of administrative support when it comes to paperwork, or it might look like weekly check-ins in a longer, more drawn out episode. It really is custom by the patient. And the benefit of having case management tied to primary care and navigation is that not only is that case manager a qualified nurse and there to provide clinical guidance and support, but they are plan aware. So let's talk about what being plan aware does for a primary care environment. When you go to your in-person primary care doctor and they recommend a gynecologist, that gynecologist is more likely than not to be a part of the hospital system that primary care physician is part of. They are more likely than not a recommendation based on that primary care physician's past experience. And they are typically recommended without any prior knowledge around appointment availability or in-network status, and without any strong detail around educational background, licensure, board certification, patient reviews, etc. Moreover, patients never know what the prior quality or cost experience of that doctor is. Unless you are actually looking at historical claims data, no patient will know the number of cases that a doctor's performed, mortality and morbidity rates, clinical quality patterns, prescription patterns, appropriateness of care scores, surgical complexity rates, referral patterns, etc. There's so much sort of below the surface, hence the iceberg metaphor, that even the smartest, most savvy healthcare consumer could never understand. And so when we make a referral in case management or in standard navigation before a primary care visit or after or instead of, we are considering network status, cost, location, patient preference, appointment availability, and quality. From a cost perspective, that's more than just, is this MRI a lower allowed amount than this MRI? We're looking at long-term cost implications of a provider choice, trends, specifically as it relates to choosing surgeons and specialists who have admitting privileges at hospitals and ambulatory surgical centers. We're also looking at quality, and it's more than does the provider get high patient reviews on health grades. It's, as I mentioned, looking at strong clinical quality patterns and experience treating a particular condition, so procedure or treatment volume, complication rates, readmission rates, etc. And all of this can be gleaned from about 13.9 billion price points of claims data that we leverage through our partnerships with Alight and Definitive so that we can better understand how to make those smart recommendations that are more than just network status. And the result is that every recommendation we're making is typically in the top 10, 15, 20% of quality and bottom 10, 15, 20% of cost. When we make a recommendation and a patient follows it, they see a 26% less costly care path and save on average $441 choosing one of our recommended providers versus a self-referral or a market rate referral. So as we kind of close out this commentary on our navigation solution, I always, as probably is not a surprise to you all, want to bring it back to a human story. We had a patient, a young male, come to our nurse team. He had been diagnosed with MS previously, as well as lupus. So he's a high acuity patient. And he had just moved, relocated. And that's pretty disruptive for a patient who is used to their care team, because reestablishing care with providers you trust when you really rely heavily on them is pretty terrifying. He had been working with one of our coaches, and that coach recognized that there were some sort of larger implications beyond navigation, including some mental health implications around this big move. And so we were able to get this patient connected with a mental health specialist, and that mental health specialist also connected him with one of our nurse advocates. And the nurse advocate was able to get to work quickly in finding not only a high quality neurologist that was covered by the plan and close to his work and had an appointment within the week, but also spent a lot of time helping coordinate the care and transfer medical records, and then continued to stay in contact with this nurse team as he was reestablishing care care in his new location beyond just the care team that was supporting the MS and the lupus. So we were really proud to be a part of his journey. This is one small example of how navigation can be impactful. If you've ever had to do research about your own healthcare, or you've been sick or sad and had to look up a high quality provider on your network website and found it daunting and exhausting and off-putting, or been confused by a bill, or felt like you couldn't advocate for yourself in a medical environment, then you understand the impact that navigation can have, especially when it is tied to the primary care that you already trust. Thank you all so much for spending some time with me today, and I apologize for being remote, or rather recorded, but I'll be back with you live next week. I hope you have a wonderful rest of your day.